We were just talking about our favorite presentation platforms, and I'm a little rusty on Teams, so please excuse me if you see the back end. I think we're good though, right, Julia? Everybody seeing the
everything looks good.
Lovely. Well, I personally am so glad to join Sandy and Jodi today. It feels a bit like a coming home for me because I am in fact a Hoosier. I was born in Hammond, Indiana. My mom's from Gary. I lived in the Midwest for part of my childhood. And so I'm just absolutely thrilled to be in your presence today talking about my favorite subject, which is food as medicine. Today, we are going to go through a little bit of the background and those overarching concepts before we talk about what food as medicine looks like in your state, at which point I'll hand it over to Jodi and Sandy, who are wonderful representatives of FMIC in Indiana. So today, as Julia said, we're going to do a bit of an introduction. We're going to talk about the concept of food as medicine, which is gaining traction and also has a big question mark at the end for a lot of people. We're also going to go through the research and healthcare innovation that our agencies do as part of FMIC, and finally end with my personal favorite in the FMIC space, policy, and what we can expect from the attention that this concept is getting across the country. Please feel free to enter any of your questions in the chat as we go through the presentation. We're going to leave generous time for discussion at the end. And Julia, please feel free to keep us on track with timing. All right, so who is the Food as Medicine Coalition? It's a very, the statement is in the name, Food as Medicine. We are a national association of medically tailored meal and grocery providers across the country. We gather together in our national coalition to provide the complete evidence-informed medical food and nutrition interventions that I just mentioned, which we'll get a little bit deeper into in a moment, to advance public policy because there isn't universal access to our intervention across the country, to continue to advance research that shows the power and the promise of food as medicine interventions like medically tailored meals, and then as a community of learning and education, peer learning and best practices, we share as nutrition science develops the practice of food as medicine and delivering it in community-based settings. Before I go a little bit further, I just want to say a bit about how we got our start. The Food as Medicine Coalition agencies largely started at the height of the AIDS pandemic, almost 40 years ago now. And we were a community response to HIV and people who were essentially at that point in the epidemic dying at home alone. And volunteers entered that situation, bringing dignity and health and nutrition into people's homes and nourishing them as long as they could. Many people early on in the epidemic passed away on our programs, but as medications came on and changed that trajectory, people started living with HIV and our missions expanded. We'll talk about that in a moment. Registered dietitians were instrumental to our intervention from the very beginning because of the nutrition sensitivity that clients living with HIV had. At that time, we were combating wasting, we were combating inability to absorb nutrients and also, loss of appetite, etc. And so our meals looked very different. As medications changed the medical needs of people with HIV, so did our diets and the way that we addressed it with nutrition. Fast forward to mission expansion, and most of our agencies serve people living with upwards of 200 different diagnoses across the country. Our clients tend to be people living with actually multiple illnesses at one time. We serve people regardless of age and regardless of income, largely across the country. And most of our agencies are supported by the wonderful work of volunteers. So we are embedded in our communities and responsive to them as we deliver this service. I also think that it's important to note that even though food is medicine from our perspective, it does not have to taste like it, right? So when someone is sick and hungry, appetite can be the first thing to go. And we pride ourselves on making delicious food that is full of nutrients and delivering it as freshly as possible to the client's door so it arrives beautiful and ready to eat. Okay, A quick snapshot of what we look like across the country. We are composed of foundational medically tailored meal providers and those providing groceries, but also programs that have gone through our medically tailored meal training program called the FMIC Accelerator, which is exactly what Meals on Wheels Northwest Indiana did, and they'll talk to you about it, so I won't steal their thunder. But you can see that even though we are well represented, there are still large spaces of the country that do not have access to this life-saving service, and that is the point of policy and research development. Some of our programs today include the Accelerator, as I just said, which is a 12-month training program that teaches embedded community-based providers in communities that don't have access to medically tailored meals how to do what we do. And that's what Meals on Wheels Northwest Indiana went through and are doing that good work in Indiana today. We also are a membership organization, and through membership, people participate in working committees. Some of them are listed here. Our clinical committee, for instance, is composed entirely of registered dietitians across the country that set and maintain our nutrition standards and the standards for delivering the medically tailored meal intervention. Also our research committee, we're going to get into research in a little bit. We run a national symposium for our membership, so you have to be a member to attend. And we offer technical assistance, peer learning, and so much more throughout the year. Finally, this year, we are rolling out our accreditation program for medically tailored meals. So stay tuned for that. It's something I'm really excited about because the quality of what we deliver is so important to the health outcomes that we hope to see and deliver to our clients. On the right-hand side are some fun stats. And now I want to dig a little bit into this concept of what am I talking about when I say food is medicine? It is a term that tends to be used broadly and has many different meanings in different contexts. So I always find it extraordinarily important to ground what we are talking about before we go too deeply into some of the field-based research and policy. What you see here on the screen is the Aspen Institute's Food as Medicine Research Action Plan. It came out earlier last year, and many folks, including myself, were advisors from the field on the actual report. I highly encourage you to read it. It's 100 pages, but it's a fast read. It's very well thought out. It essentially asks all the right questions. What do we mean when we're talking about food as medicine? What interventions are included? What does the field say now? It is, as far as I can tell, the best summary of all the research in the field that exists right now. And then it makes 26 recommendations for how to move research forward from an equity-informed perspective and with the participation of community. We feel that that is really important in the Food as Medicine Coalition. So the way that the Aspen report defined it from its community of advisors is really an important piece of grounding what we say when we say food is medicine. And what they said was the provision of food that supports health, like medically tailored meals. And then there is also the nexus to the healthcare system. So I'm going to explain what the medically tailored meal intervention is, and it'll help you understand how closely tied in we are with someone's clinical care plan and the outcomes that they hope to expect having gone through treatment. In this conception, the Aspen report identified 3 promising programs, 3 promising interventions that really fit right now that definition of food as medicine. Does not mean that it's exclusive, it is just where the evidence base is right now. Those 3 interventions are medically tailored meals, medically tailored groceries, and produce prescription programs. And before I go to the next slide, I just want to say, right now, as a result of the White House conference and so much attention being paid to the concept of food as medicine, even though, as we all know, it's an older concept. I mean, we could go back to Hippocrates, right? There is a lot of meaning making happening right now. We are all asking this question, what is food as medicine? And this is a really solid place to begin that discussion. I also want to make the point that it's an evolving concept. So this is a snapshot of an article that I wrote along with some folks from the CDC and Tufts and the Center for Health Law and Policy Innovation. It was featured in Nature. It's a nice short read. I'll send some links to Julia after, but you can see here that it's conceived as a pyramid, and that by no means means that the highest part of the pyramid is the best intervention. It's actually describing a population. So the people that need the very specific intervention that is medically tailored meals are a much smaller piece of the population of the United States than those that need access to population-based healthy food programs. We all should be eating healthily, or have the opportunity to eat healthily from an equity perspective to achieve the best health outcomes. So what you're seeing here over on the left-hand side is a progression from using food for prevention to using food for treatment, which is where medically tailored meals are, and increasingly those programs underneath. And then also the population diminishing because only a very small subset of our population needs that intensive intervention. Again, this is evolving. I personally am starting to think of this pyramid more as a speedometer. So people might not need that high test intervention that is medically tailored meals until maybe they're going through cancer treatment, or they develop Alzheimer's and need minced or pureed meals instead of meals that are just delivered whole. So it's a really an interesting concept to think about, and the whole field is paying attention to it and discussing it. More specifically, let's talk about what is a medically tailored meal. I'm going to go through step by step, and please, as I said, enter any questions you have in the chat. Sandy and Jodi are going to contextualize it for you in the real service that's being delivered in Indiana, but I'm going to talk about it from a little bit higher level. So you heard about our history, but broadly speaking, medically tailored meals are medically appropriate meals that are delivered to the homes of people of all ages who are living with complex, severe, or chronic illnesses and who are too sick to shop or cook for themselves. So that last phrase is more of a vernacular way of explaining that many of our clients have activities of daily living limitations that actually prevent them from cooking, prevent them from shopping. So even if they have access to SNAP benefits or have a budget for groceries, they're physically unable to go buy those groceries and also to cook them. That is not always the case. For instance, many of our programs have developed medically tailored meal programs for pregnant people who are encountering gestational diabetes. We're looking at the first 1,000 days of a baby's life and how that sets a child up for health. So there are different ways that medically tailored meals are being deployed and tested, but primarily they are for this population that I'm describing. Who is eligible? So eligibility is not here. I am eligible for this benefit. We're going to get to policy later, but really more about who best benefits from the intervention medically tailored meals. And most agencies actually have eligibility requirements that they set. As I said, someone with severe or chronic illnesses. And then there's that really important connection, going back to the Aspen report, to the medical or clinical continuum where a referral is received by a medical professional or healthcare plan. That does not mean that the referral has to originate there. We have a no wrong door entry policy where your brother, sister, second cousin, thrice removed can call on your behalf and say, my family member is sick, they need meals. And then the agency will go through the process of confirming with their medical professional and embedding our service in that clinical care plan so that we're all working together. What makes MTAMs different from other meals? This is such a common question, right? The whole point of medically tailored meals is that when someone comes on program, they go through an in-depth assessment with a registered dietitian that actually makes their meal plan for them, for their allergies, medications, comorbidities, to a certain extent preferences, although we are really encouraging of eating new and diverse foods. And we layer those needs to create a meal plan that that person can actually eat. Imagine if you were living with HIV, diabetes, and renal failure all at the same time. It'd be very difficult for you to figure out how to manage all of those restrictions and still eat something that tasted good. So that's what we do for folks. People receive medically tailored meals in a variety of ways. We look at ourselves as gap fillers in some respects, filling in for where a person really needs our help, or as providers of full nutrition up to 21 meals a week. We recommend that medically tailored meals be received for at least 3 months to see any sort of impact on someone's health, but 6 months is really the highest recommendation. And then people, of course, are reassessed. Throughout the intervention, a medically tailored meal client will receive access to registered dietitians. They can call up and say, hey, my medication changed, and I can't eat X, or I don't like fish anymore, please stop sending it to me, I will not eat the fish. Those types of things. Or I don't know if I'm eating the right thing here. Could you tell me? Could you educate me? And that intervention extends far beyond the medically tailored meal service delivery. Our goal is to empower our clients with the tools of health through nutrition, and research shows that our intervention improves health outcomes, lowers healthcare costs, and from a mission perspective, makes people happy, right? Receiving delicious food at home is a part of healing. And then we're going to talk a little bit more about this research, so I'm not going to belabor it, but there's huge benefits to receiving this service. So I've talked about research a lot. The reason why medically tailored meals is receiving a lot of attention now, even though it's an older concept, is because over the last 10 plus years, peer-reviewed studies have shown some really impressive outcomes if medically tailored meals are added to someone's treatment plan. A 16% reduction in net healthcare costs, 72% fewer skilled nursing admissions after hospitalization, and here we missed one, 50% reduction in initial hospitalization. And then just recently, JAMA published a cost modeling study that looked at what would happen to nationwide healthcare costs if anyone who needed MTM got it. And you can see $13.6 billion net saved in the first year. So that's inclusive of the cost of paying for the meals that are so delicious. Finally, we as a coalition also participate in local studies. And you can see a few here looking at populations and how medically tailored meals works with communities in different situations. So despite all this awesomeness, I mean, I know that we believe in it here, that's why we're here, but it's clear from the research that it works too. There's still no dedicated federal funding for what we do. Most of our agencies across the country are raising the majority of their budget. So not SNAP, not WIC, not OAA, Older Americans Act funding. None of it is set aside specifically for this intervention. Now, over the last few years, especially since the advent of the Affordable Care Act in 2010, many states and individual plans have used some of those flexibilities to begin to reimburse our agencies for the services we provide and expand coverage for people in need. However, even in that context, in Medicaid, which is for people who are low income, there is no dedicated benefit. It's really in states that have chosen to submit a waiver or use those flexibilities that it's available even to a small population. And then in Medicare, which serves the elderly or older Americans and people living with disabilities, only Part C, which covers only a portion of people in Medicare, has flexibilities at all to cover medically tailored meals or nutrition, and that's only by choice. And you can see, I think, across the country, COVID-19 really only highlighted this gap in service. So what is our response? Well, we robustly participate in healthcare innovation across the country. Here are all the lovely acronyms and waivers and flexibilities that we have leveraged to be able to serve more people living with serious illness. But even in the face of all of these fun acronyms, they're still on the margins of innovation, and we don't have a dedicated way to leverage this service across the country. And so this is where our advocacy comes in. We're thrilled by the introduction of a bill, HR 5370 in 2021. It's called the Medically Tailored Home Delivered Meal Demonstration Pilot Act of 2021, a mouthful, but an important one. It was introduced in a bipartisan way, and what it did was model the intervention, medically tailored meals, in a piece of Medicare really dedicated to the hospitals, and proposed using it really as a giant research study that could help us understand how the intervention worked in different geographies and with different folks. It had 50 plus co-sponsors when the last Congress ended, and through our advocacy and education, we were able to raise awareness about the intervention because it can be somewhat of a foreign concept to people who are even in the food space. We write policy comment letters urging the incorporation of health-related social needs into healthcare. And there has been, as a result of ours and others' advocacy, tremendous movement toward more states adopting those flexibilities and using them to the advantage of their clients or their enrollees that are in need. Of course, I couldn't talk about policy without mentioning the White House conference that happened last fall. It was the result of tremendous advocacy on the part of Congressman Jim McGovern from Massachusetts and others who have tirelessly fought for anti-hunger policies and attention on the health impacts of what we eat and how we provide it to people. We were extraordinarily engaged in the White House conference and privileged to be. Our chair was one of the only CBOs or community-based organizations featured on a panel at the White House conference. If you navigate to our web page, which I'll drop some links in after I'm done, you can see our response, and it was pretty robust, including featuring a powerful collection of client stories. Most important, out of the White House conference came a national strategy that is really pointing the direction of the country from the perspective of the Biden-Harris administration around food as medicine and other hunger and nutrition related policy. Medically tailored meals over here on the left was featured really front and center, I would say, in Pillar 2. And we are continuing to pay attention to those evolving policy needs. This is my last slide before you hear from your fellow Hoosiers in Indiana. I guess it's sort of an honorary one, but I would count Jodi and Sandy as the real ones. But what now? After all of this evolution and all of this attention, where we've recognized through research, through experience, and through the witness of our clients that food as medicine and medically tailored meals works, and we have the attention of the administration and national media, what is happening now? Well, the media attention continues. My personal feeling is we are at this moment where we've gone from what is food as medicine to, well, of course, food is medicine, from personal witness or research or whatever, to, but how is food medicine? And should we be really incorporating it into healthcare? So I've just listed a few of the areas where that conversation and discussion is happening. And I welcome your feedback on that, and we can maybe talk about it in Q&A. CMS, the Centers for Medicare and Medicaid Services, that governs the larger public insurance funding streams in our country, has promised guidance on how to use these interventions with their flexibilities. And we're participating in that process where there is one. NIH, the Office of Nutrition Research, has released a Centers of Excellence concept that is looking at, in some ways, actioning some of those Aspen report recommendations with the community and an equity-focused research concept. It is not funded yet, so it's just a concept until it actually gets funding, but it's very encouraging. And then Tufts and others are reconvening a national summit in April to keep this conversation alive and make sure that we're really paying attention to it, even as large legislative movements happen this year, like the USDA Farm Bill. And so I really encourage you to stay involved with FMIC. We hold quarterly meetings for the field. The next one is in April. You can sign up for our listserv at the bottom of every page of our website. And with that, I'm going to hand it over to Jodi and Sandy to talk about what does this look like in Indiana. Oh no, Sandy, I don't think we can hear you. No, still can't hear you. Oh no. And Jodi, we could before too, so I don't know what happened.
I know.
Oh, the vagaries.
Right. Try one more time. Nope. You want to come to my office?
Oh, good.
I feel like we should play music or something while she's in.
Yes, I promise not to sing.
Me also.
It's a little scary.
I know. I'm gonna sit here.
Oh.
Hi, Sandy.
Jodi?
Give us just a second here, guys.
Yep, take your time. I hope everything's okay, folks, but maybe in the interim, if there are any questions, I could answer them.
Yeah, it doesn't look like there's anything in the chat right now, but if anyone wants to come off mute and ask a question or ask a question in the chat while we transition, we can do that.
Hi, my name is Alissa Wassung, and I work at the Marion County Public Health Department here in Indianapolis. And I work more on nutrition incentives, so know a little bit about food as medicine, but definitely not my wheelhouse. I'm interested, like, as things get moving at the national level, do you think there's still going to be a push of like the 1115 demonstration waivers kind of first, and like, is that still an important part of the conversation, or is it kind of expected to be more at that national level?
So I absolutely think that there is still a huge focus on 1115 waivers. In fact, in the national strategy, it was the recommendations in Pillar 2 for MTM and other interventions was, let's look at 1115 waivers and let's look at the legislation that I mentioned, like how do we do more pilots? I think for advocates that have been paying attention to this for a long time, we are hoping that that conversation progresses to let's make it a benefit so that there's actual equitable access across the country. But for the time being, those 1115 waivers and demonstrations are going to figure large in the next steps around food as medicine. So even in Illinois or Indiana, you're seeing a lot of movement in that direction. Jodi, how are you all?
We're good.
Okay. Should I pass it to...
I sit on a ball chair. That's not always conducive for everyone.
Oh no. Oh no. Okay.
So apologies for that. We're back.
Okay, good. I'm gonna pass it off to you, but at least if I didn't answer your question completely, we can totally come back to it. So Jodi, over to you.
Yeah, great. I am Jodi Bell. I'm Director of Business Development with Meals on Wheels of Northwest Indiana. Sandra is our CEO, and we went down this path. I'm very passionate about the food as medicine and medically tailored meal intervention. So when we were able to connect with FEMIC and participate in the accelerator, it was extremely beneficial for not only those in our community, but me personally as well. So I'm a huge fan of this. We can go to the next slide. I feel weird having you do that. So we started as a Meals on Wheels program here in 1977. Started as a function of the VNA. So we've always been rooted in healthcare. The nurses in the area saw that individuals who were recovering at home and dealing with illnesses were not receiving the proper nutrition to keep them healthy. So they started a Meals on Wheels program. Started very small in one city, and we have now grown to where we serve over 7 counties in Northwest Indiana. So we've continually evolved. We do produce our own meals. So we are responsible for our food sourcing and the quality of that, which we find is also extremely important in what we do. And we take great pride that we prepare meals from scratch. The evolution of therapeutic meals to medically tailored meal. And this kind of goes back to Alissa's statement about making sure that we're kind of grounded in the same area, so that she brought up a very valid point, and Julia spoke to this too. food is medicine. It's like this huge thing. We all have these like concepts of what it is. And fortunately, a lot of little things play into it. And on that pyramid, you can see that there were different levels of things that from prevention to treatment. So at Meals on Wheels, we were currently doing what we consider and defined as a therapeutic meal. So where it might address that one chronic illness of diabetes as a carb counted meal. What we couldn't do is address the individual who had renal disease, but still needed to address the diabetes and the congestive heart failure, which is a multi-layered diet. And we found that that is so much more impactful, as the research has shown as well. So we just knew we had to move into this. We still offer these therapeutic meals because we know that addressing a chronic illness or even just managing it, having the appropriate nutrition is a huge impact on that. So we offer the therapeutic meals as well as the medically tailored meal intervention. Next slide. Kind of went over this already. So you know, lots of times, you know, if someone mentions that it's a medically tailored meal, we try to make sure that we've clearly communicated what we mean by that. So while we agree food is medicine and there's a level of prevention, and that's going to include everything from making sure someone who's in a food swamp desert has access to nutrition, to pharmacy boxes, whether you spell that as a prescription pharmacy or as a farm, F-A-R-M box, and on up to the intervention of the medically tailored meal. The medically tailored meals, some individuals across the state, I shouldn't say individuals, groups offer what they call a medically tailored meal, and that meal is tailored to a specific chronic illness. So that's considered too. So we have those across the state of Indiana. And then we have, I believe it's us and Central Indiana that are doing the medically tailored meal intervention, which is very heavy on the registered dietitian, nutritionist involvement, making that specific to an individual and that individual's multiple layers of health care that they need. Yay, Sandy's back. Okay, next slide. This is a little more colorful pyramid. I believe it's also used by the Food is Medicine group in Massachusetts. I'm a color girl. I like, you know, Post-its and all that kind of stuff. So this works for me. And as you can see, it goes from prevention to treatment. We currently have something at every level of this across the state of Indiana. Sometimes what we don't have is the knowledge of what everybody else is doing across the state. I do believe that, and I thought I saw her name come up, Michelle Shipley, Shippey, from Marion County Health, was trying to do at one time, and I'm at fault for not reaching out to her before this, to figure out where she is and trying to get all of us who are doing a piece of food as medicine across the state of Indiana together. So, you know, we're talking at the beginning, the prevention is going to be, you know, your food banks, a food pantry, and then you get just more individualized as we go up. And right back to what Alissa said, these are all extremely important layers of what food is medicine is. No one is more important than the other. Them all working together is what is impactful. That's quite possibly, you know, we have individuals who are on the medically tailored meal program who achieve a sense of being able to move off of that, but they still would need medically tailored groceries. And so having those partnerships within the community and knowing what everybody is doing is going to be beneficial to all Hoosiers as we can move individuals through the spectrum of what we are doing as food as medicine. Next slide. Alissa did a wonderful job on this. And why our approach is a little bit different is it's that home delivered meal that improves the health outcomes. So we are fortunate that the medically tailored meal intervention and FEMIC has done a wonderful job of research, you know, collaborating on research, getting it all in one spot, and actually having evidence-based research that proves that what we do is an outcome. There's other research that shows what some of these other programs within the food is medicine pyramid that do, but I would say the most research is done in this medically tailored meal because it's just so impactful. So that was also something that we know in looking at health statistics across Northwest Indiana. We knew that this was something where we could truly impact the lives and the health of Northwest Indiana residents. And so we were excited to bring this on. Next slide. Full disclosure, I pretty much stole this. I don't believe in recreating the wheel, and again, it's colorful and it's pretty. But this is for individuals who are very logic oriented and can see clients in the medically tailored meal intervention are referred by a medical personnel or a health plan. Those nutrition assessments are done by a registered dietitian with that individual one-on-one. Then those meals are individually tailored for that individual and prepared from scratch in our kitchen. We deliver the meals chilled. We deliver 14 meals at a time, meals and beverage. And that gives those individuals, 2 meals a day throughout the week. And then they have great tasting meals, as Alissa referred to before. And I think we all know this. When you don't feel well, you can't cook for yourself. You can't get to the grocery store. And if you add on other social determinants of health to that, it just compounds that even more. And so if you can have something that actually tastes good and help yourself recover, it's better for the community as a whole. Clients do see improvements within a 12-week period. And so that's when we reassess. We use a 12-week period and either make alterations based on where they are in their medical journey or, treatments, etc. And they either come for another 12 weeks or we move them to a different level of the pyramid. And Alissa, next slide. This is forcing Alissa to pay attention to me. So some of the things in terms of treatment versus prevention doesn't necessarily have all of the aspects involved that we have in terms of menu development. So when we're developing a menu, whereas it's really not as intensive to come up with a menu that and a certain carb counted diet, you can come up with meals for that. And now you start doing a carb counted with a renal and a congestive heart failure. Now you've got all these layers. So menu development becomes a little bit more challenging. Meal packaging becomes more challenging because of what we were, doing. And so that takes into consideration. The client relationship management is a little different because we're integrating with these clients for a minimum of 12 weeks. So we really do impact that individual through conversations with just the client services team, through medical nutrition therapy, through nutrition education. So there's a lot more client focus than sometimes you have with just either a pharmacy or a food pantry. The nutrition part of it, our staff has become way more aware of all kinds of different nutritions. I'm not going to lie, we still have donuts, everything in moderation. But the staff has become much more aware, and so that's more focused. In addition to, we have been HIPAA compliant for quite a long time, but now we have really stepped up in dealing with healthcare and all of that, of what the HIPAA and the confidentiality and all of those layers of things. All right, next, I'm trying to watch my time. Okay, next slide. There we are. I do want to wrap up just real quick. There's really is a lot of things happening across Indiana. There is, there are produce prescription programs that are happening. There are therapeutic food pantries. There are food pharmacies. There are disease-specific food boxes. All of these things are happening in Indiana. I know IU has a lot of things that they do. Almost everyone on here, I'm sure is familiar with the iHope and the partners and those social determinants of health and getting to that. So I just you know, I'm super excited to see how many people are interested in this. I'm thankful to Alissa for all the training and the knowledge and stuff that we've had. And I know that our clients and who we are impacting in Northwest Indiana is just, it's an amazing. So we do serve people of all ages with this program. So I know we're a Meals on Wheels program, but even our Meals on Wheels therapeutic side, we serve individuals ages 3 and up. So I am open to any questions, or if anybody wants more knowledge or wants to share what they're doing, I think that'd be wonderful.
Great. Thank you all so much for taking the time to come present today, and we will open it up for questions. So we have one question in the chat right now. It says, when, I think it's referring, it was after you presented, Alissa, when you said 1.3 billion saved in healthcare costs, is that for individuals or to insurance, or is it a mix?
Great question. So that's looking at overall healthcare costs, like the aggregated costs of what we spend on healthcare. So these are public funding streams. Largely, most of the savings was seen in Medicare and Medicaid, because that is where many of our clients are receiving their insurance coverage or their care. So it was overall cost, not to individuals necessarily. Folks in Medicare and Medicaid are receiving insurance free of charge largely, unless they decide to elect certain coverage through Medicare. So it's really looking at the overall healthcare savings. I hope that helps.
Wonderful, thank you. Thank you for your question, Sarah. Go ahead, Alissa.
Elise, did I answer your question about 1115 waivers? You may not be there, but if anyone has any questions about the policy pieces, I know that that can be kind of wonky and really like rife with acronyms. I will say that 1115 waivers for our Medicaid population are becoming more normal now, really spanning states that may or may not have expanded Medicaid under the flexibilities to the Affordable Care Act. It's really important to know that Medicare is a nationally administered program. So if you make a change, it's national automatically. However, Medicaid is a state and federal share. So each state can elect to do something different. In some ways, that's really beautiful because it allows a state to answer the needs of its specific population, but it also presents challenges where one state might have a more progressive or innovative Medicaid program and maybe serving their clients or their enrollees in a different way than another state. And that other state may not have access to that kind of program. So it creates a lot of variability across the country and a lot of confusion for enrollees. So we're really looking at kind of broader changes that incorporate food as medicine interventions as a normal and natural part of healthcare.
I did want to, Shana had put, and Shana Cash from Polytech High School. I know probably what we talked about here didn't address what you were hoping about integrating food as medicine into your school food program. Farm to School in Indiana is a great program. It's also a national program. And there are just multiple ways that you can do that. And that's absolutely in that prevention level of the food as medicine program. So super excited that you want to work with kids and getting that started, because we all know that's impactful as well.
And to piggyback on what Jodi said, which is an excellent point, there's actually a large movement using the Center for Good Food Purchasing Standards around leveraging the purchasing power of schools to buy better food and to buy food that honors local workforce and animal welfare and other things. And it's a larger movement with hospitals, cities, and schools. It's called Anchors in Action. And if you're interested in that concept and some of the standards and understanding what your school might already do, there's a lot that I think schools do and don't talk about, just like nonprofits. Like we already purchase largely locally, but we're not talking about it, you know? So I think that it's a really valuable framework to get involved with. Healthcare Without Harm leads it from the hospital side, Center for Good Food Purchasing with their Good Food Purchasing program. And then there's also a campus, largely for college campuses, but a campus-based Good Food Purchasing program that is also involved. I don't know, Julia, if there's other.
Yeah, Allison has a couple of questions here. She has, have you added education or cooking classes to your programs? We'll start with that one.
I'm going to let Sandy and Jodi answer specifically for Meals on Wheels, Northwest Indy, but most FMIC agencies have. So that pyramid is extremely important. We have people who go through treatment and then may not need our services anymore. Like people who are going through cancer treatment is a great example. During surgery or radiation, they might need that medically tailored meal component, but then during that experience, we want to help them understand how to eat right for their condition, and might combine what's called a step-down program that includes cooking classes, a medically tailored grocery program that has recipes in there. They can talk with an RDN so that when they go back to maybe not needing our services at all, they're armed with that knowledge and understanding and can cook for their life. The Cook for Their Life is actually a program that we participate in for breast cancer survivors. So absolutely, yes. And God's Love We Deliver, which is in New York City, where I used to work, has a test kitchen, like a teaching kitchen, where they do in-person and virtual trainings. Jodi and Sandy?
Sure. Well, we don't actually do the cooking lessons and all of that. We're just not at that point yet. What we do like to refer out to is our wonderful Purdue Extension people who do a lot of community teaching and classes and those kind of things. And so we try to refer them out to those and make them aware of the programming through that.
And I think that that's a great example too of local incorporation, right? It's going to look different in New York City than in Indiana, than in rural Indiana, right? In rural New York State. So we need to really, answer the structure that's there. And that's what FMIC tries to do, is work within the structure that exists, not reinvent the wheel, as Jodi said. Because it's really important to not throw up barriers for clients in need, but try to eliminate them so that they understand the services they're getting and how to access them.
Well, and Allison works for the nutrition education program within Purdue Extension. So go Purdue Extension people. I know there are a lot on. Allison also asked, do you have medically tailored meals focused on diversity or different ethnic communities?
Yes. Actually, this is National Nutrition Month. I should have said that at the height of our call. It's also National Kidney month, and there are several other. RDN Day is March 8th. It's like a big deal for our coalition and other food-focused providers. So we do incorporate cultural diversity and different menus. Again, I'm sorry to keep saying this, but that's why it's so important to have a local program. One great example, and we're going to feature some of that throughout the month, so pay attention to our social. But one great example that we had featured at our national symposium is Open Arms of Minnesota, just sort of north of you. They actually just incorporated 3 culturally specific menu consultants into their program, one for Latinx populations, Hmong populations, and then also East African populations, because those are the populations they primarily serve. In New York City, we did a lot of work with Chinese American cuisine and trying to understand how better to serve that aging population. So I think it really depends on that culturally specific environment that we find ourselves in. The other piece that I think is important to mention is our roots. Many of our agencies have roots in the HIV epidemic and are actually serving people with HIV through the Ryan White program, which is a national program that supports provision of support services and medical care for people with HIV. As providers in that program, we adhere to the class standards, the culturally and linguistically appropriate standards out of the Office of Minority Health. It's a wonderful opportunity to just take a look at those standards and also the sort of presentation of our meals and our nutrition counseling with an anti-stigma lens.
Wonderful.
Yeah, absolutely.
Are there any other questions for our team here?
If you all are interested in a fun listen, we were featured on a gastropod podcast in October. That's just a really like kind of short and helpful understanding of medically tailored meals in the state of the field, and done by two fabulous hosts. I can give Julia the link to it. But if you want more information too, I'll send some helpful links and one-pagers and kind of further interest deep dives.
Absolutely, that sounds great. And yeah, for those of you who had issues seeing the PowerPoint, I also know that when we upload recordings to YouTube, sometimes the PowerPoints aren't there. I don't know why, but we will have all of that for you. And like Alissa said, any of the information that she shared, we will also share in the coming weeks. All right. I'll open it up one more time for questions, just last minute, if anything's come to mind.
And I'd love to
Once?
connect. I'd love to connect with anybody who has a program of food as medicine, and we can start to like figure out what we're all doing across the state, so we can, you know, work on that together. So if anybody wants to reach out to me, I'm happy to, you know, start making connections with all of us and get us all on the same page.
Absolutely.
Jodi, this is Antonia Sawyer. I lead the Hoosier Health and Wellness Alliance, and we're actually working with Karen Shore to kind of identify the role health coalitions play in the food system. And I'm almost confident that food as medicine has come up more than once on our current like survey that we have out, as well as talking with like key stakeholders across the state. So I would really enjoy connecting with you and kind of sharing her report with you. And if food as medicine is in there, your expertise would be priceless, because I'm new to the food as medicine space and like the food system as a whole, but I'm eager to learn and would love to collaborate if appropriate, and you see a space for that.
That would be great. I would love that. Yes.
Yay, Faye.
And I love these connections. And I also just want to say, many of our agencies are thinking really deeply about how to serve rural populations. That Medicare pilot I mentioned has a piece of that. And, you know, we are pretty adept at using telemedicine and shipping too to meet the needs of communities. So just wanted to mention that as you embark on thinking about serving or mobilizing a rural health network around food as medicine. Very cool.
This is Alissa Wassung again. Another question. I just think like I know a lot of us on this call are a bit more in the public health sphere of things. How does the public health sphere and those kind of expertise link well with kind of the CMS or Medicaid side of things to move this work along, especially like in a coordinated statewide way?
Such a fantastic question. And I think the first thing that I want to say, because I think this is like another hour-long conversation, is I think one of the other things that COVID showed us is that we don't have a public health infrastructure. That is just not, we are invested in healthcare, but public health is something that we have to pay attention to. And I think that there are ways, especially on the prevention side and the population-based services side, there are huge opportunities to think about mobilizing food as medicine interventions along the whole continuum. So we're really focused on treatment. Of course, medically tailored meals, medically tailored groceries are also prevention. They're preventing further degeneration. They're preventing adverse events. We understand that. But I think that there is a tremendous opportunity across that spectrum for public health to support the structure of access and knowledge as well, right? That food and nutrition and health obviously belong together is not necessarily something that is widespread as a common understanding. And so I think that there is a lot of opportunity there, and it's a subject maybe you all could talk about, especially from a state-based perspective. How do we support food as medicine, access, education, and understanding within the public health infrastructure? I hope that it was kind of a broad answer, but I think it's a deeper conversation, but I think it's really important, Elise.
Or just answering the question in the chat here. Yes, all this information will be shared. I know that, and I spelled SNAC wrong. That's fun. We will share it to our larger SNAC listserv, and I know that some might not be on that SNAC listserv. So luckily, Teams pulls all of the people who have come, and then I can send it out to just the attendees as well. But again, thank you all so much for taking the time to speak with us today. And just, I'm already seeing the collaboration and promoting questions. So it's fantastic. And I really appreciate your time. And for our group here, we do have another series, another webinar at the end of this month. As you all could imagine, it's about policy and how you can really work with your community to leverage their voice to make changes at the local, state, and federal level. So we have our friends from the AARP coming to speak about that. It was supposed to be in February, but as you can imagine, it's a budget session. It's very busy here. So it was harder to get them on the schedule, but we have them at the end of the month, and we'd love for you to join us. You can sign up at the link in the chat, or you can scan it on the screen with the QR code. So thank you all so much for your time, and we will send all this information out.
And thank you, Julia. It's lovely to be in conversation with you all.
It was nice to have you back home in Indiana.
Yes.
I even went to IU for a time, so I really
Wow.
it actually counts. I'm really, really happy that these connections were made, and I wish you all the best on your food as medicine journey.
Thanks, Alissa. Thanks all. Have a great day.
See you.
Bye.